We're going to talk about NG tubes and doing NG feedings, enteral feedings, and I'm going to go over some of the different equipment that we'll be using. There are different types of tubes. There are large bore tubes and small bore tubes, tubes that can be used for feedings and instilling medications, and then there are tubes that are used to decompress the stomach. That'll be the first one we'll talk about. It's called the Salem Sump, and this is used for gastric decompression. You can instill fluids into it, but we don't typically use these for feedings. You'll see these a lot of times after surgery. This end, you can see, has several openings on it. That's the end that's placed into the stomach. This port is what's connected to suction, and this is called the air port, or we call it a pigtail. We don't put anything into the pigtail or connect anything to the pigtail. This is an air port that allows air to be suctioned from the stomach so that this tubing does not connect to the gastric mucosa. So it keeps you from having any damage to the mucosa when you're suctioning fluids and things from the gastric area. The other type of tube we're going to talk about is a small bore tube. There are different types. They come in different lengths and different sizes. This one is an 8 French, and it's 45 inches in length. Small bore tubes come with a stylet, which is a wire inside that's used as a guide wire. And you can see that's right here. And you want to leave that in place for insertion. It makes insertion of this tube very easy. You can see that it's a rather flimsy and soft tube. If you didn't have that stylet inside, it would be very difficult for you to intubate your patient with it. This one also has a weighted end, and this is to help keep it in the stomach, and it can also be used to pass beyond the stomach into the small intestine. After you place this tube, you remove the wire stylet, and then you can connect feedings or use this port here for medication administration or feeding administration. Now, some of the other things that you're going to need when you're using a tube is you're going to need what's called an irrigation tray, and this has a piston syringe and an irrigation bottle. So we'll need that. You're going to need some tape. You need to mark the length of your tube so that you know how far to place it into your patient, and then you're also going to have a way to secure the tube to your patient's face after it's put in. You'll need a tongue blade and a pen light and your stethoscope, a towel, an emesis basin, and some test tape. So I'm going to start by intubating this model with the small bore so that I can show you the anatomy and where this tube is actually going. So after you check your physician's orders and you've instructed your patient, you want to have gloves on. These have a self-lubrication on the end of them, so all you have to do is just place it in some water or saline, and that will activate the lubricant. You would measure your tubing, which I'll show you on the other mannequin in a moment, and you would just place it into the nair, and it would go down the throat and into the esophagus until it gets into the stomach. And here you can see it's entered the stomach. Then you can check placement and remove the stylet. The stylet comes all the way out and goes into the sharps container. Now I'll show you how to measure and insert into the mannequin. Okay, so I'm going to take my tubing and I'm going to measure from the nair to the ear, and then from the ear to the xiphoid process, which is right there. And I want to mark that place with a piece of tape so that I don't go past it. I'm going to lubricate it, and I like to go ahead and put my syringe on the end of it. So I'm going to lubricate the tip. Go ahead and get my stethoscope on so I'll be ready to listen and check placement. Okay, so I'm going to place it gently into the nair and slowly advance it. I'm going to ask my patient to swallow. I'm going to move their head forward when I get to the back of the throat. So I just want to continue pushing until I get to my tape. Now I can take a piece of tape and just secure it to my patient's cheek and check for placement. So what I want to do is I want to aspirate a little bit of stomach content and squirt it into my emesis basin. Put my litmus tape in there so that I can ensure that it's in the stomach. After I checked my litmus tape, I'm going to go ahead and instill some air and listen over the stomach with my stethoscope for a whoosh, and that's just the air entering the stomach. I'll push that air in and hear a whoosh, and then I want to aspirate that air and some stomach contents, and that pretty much tells me that it's in the right place. Then I can chevron my tube into place. So what we have is a piece of tape that's split halfway down the middle. I'm going to place part of it on the nose, and then I'm going to use these pieces that are torn to wrap around the tube and secure it. Okay. So now I can remove my stethoscope and place a plug in the end of it so that it doesn't leak all over my patient's bed, and I can pin it to the patient's gown with a safety pin right here. So after I get my small bore tube in to my tape marking, I'm going to go ahead and place a Lure-Lock syringe. It needs to be at least 30 cc syringe or larger onto the end of it. I'm going to put my stethoscope in and check placement. Over the stomach, instill the air. Listen for the whoosh. And then I want to tape the tube in place. I would tape it to the side of the patient's cheek. And typically these patients are sent for a KUB x-ray or an x-ray of the abdomen to make sure that the tube is in the stomach and not in the trachea or in one of the lungs. So after the x-ray department calls and tells us that the tube is in the correct place, then we can remove the stylet and begin to use the tube for whatever purpose it was placed.